It's Dr. Dmitry Borzunov is going to talk on bone defects and non-unions.
Currently, most of the authors consider two methods of bone transport to be the most effective and alternative ones. Non-free bone plastics by Ilizarov and grafting by complex of tissue with present vascularization, including free autograft into the defect. Common in the technologies is maintaining vascular connections with soft tissues of the segment, adequate blood sample, resistant to infection and capable of complete organotypic remodeling. Filling in of post-resection radial defect formed after resection of osteoblastoclastoma by free fibula autograft with venous arterial shunting. Advantages and disadvantages of free vascularized bone autograft. The first experimental model of filling in post-resection tibial defect by lengthening of the proximal fragment. True bone defect is any loss of bone tissue and total amount of interfragmental diastasis and anatomical shortening of the segment. Defect classification: defect pseudarthros, defect diastasis. In Ilizarov transosseous osteosynthesis adaptation of the docking site, closed and open coaptation of the bone fragments, and maintaining compression between fragments depend on a complex of factors. Congruent ends of bone fragments, closed adaptation. Non-congruent ends of bone fragments, open adaptation. There are different shapes of end of bone fragments. The diagram of creating longitudinal axial compression. Clinical example. Technologies for close consolidation of ends of bone fragments, creating side-to-side compression with a long connecting plate. Clinical example. The use of technologies depending on the mobility of fragment. The types of osteogenesis and the types of osteogenesis: hyperplastic, normal, atrophic. You can see the etiology of pseudarthrosis and classification by involvement segment. And in terms of infection, the main aim of treatment and rehabilitation is restoration of anatomical and functional integrity of the limb. The system of reconstructive and restorative treatment of the patient with long bone defects by Ilizarov is based on the following principles to rehabilitation approach: fragments lengthening, healing, at the docking site, tibia, fibula, synostosis, and gradual tension of interfragmental tissue with a regenerate formation. All technologies of transosseous osteosynthesis have fundamental theoretical grounds. Monolocal distraction compression osteosynthesis. The techniques of filling the defect by lengthening of fragments with formation of the distraction regenerate is presented by bifocal osteosynthesis. In modeling conditions of bone transport, for the amount of 20% of the original left of tibia, the bone herring of the distraction regenerate in the docking site was observed by the 90th day of fixation. Multi-level lengthening of the proximal tibial fragment. Polylocal distraction compression osteosynthesis, multi-level lengthening of the proximal fragment. In the experiment in post-resection tibial defect of the same amount by multi-level lengthening of the fragment or opposite fragment lengthening, the duration of osteosynthesis was described by 1.5, 1.7 times. The processes of distraction osteogenesis in polyfocal bone transport were characterized by high level of endosteel and peristeel bone formation. Multi-level lengthening of the distal tibial fragment. Polylocal distraction compression osteosynthesis, multi-level lengthening in the distal fragment. Filling in the tibial defect by lengthening of the both tibia fragment. Polylocal transosseous osteosynthesis, lengthening of fragments towards each other. Tibia fibula synostosis is presented by the method of monopolyfocal bypass synostosis and was characterized by high level of the plasticity and reparative formation of the bone tissue. All experimentally tested technologies of filling in the bone defects and pseudarthrosis are currently widely introduced into clinical practice. Distributions of pseudarthrosis and defect by localization is presented on the slide. The same on the monolocal transosseous osteosynthesis. Monolocal compression distraction osteosynthesis for pseudarthrosis with angulation. Placement of hands for correction of stiff angular deformity is pseudarthrosis. Patients with diagnosis post-traumatic stiff hyperplastic defect pseudarthrosis of the tibial bone with varus and anti-curvation deformity. Duration of the disease is 3 years old. Transosseous osteosynthesis of tibial bone using Ilizarov frame. Osteotomy of fibula and metal removal were performed. Distraction was produced over the traction junctions, place of the posterior medial tibia. Full restoration of the anatomical segment integrity was obtained. Patient with aim fails joint. Open adaptation of fragments, compression of the docking site. Treatment result. Bilocal transosseous osteosynthesis. This is him. Patient with diaphyseal ulnar defect. The defect was filled in due to proximal fragments lengthening. There was an open fragments adaptation at the docking site. Patient with defect of tibia bones after gunshot wound, arteriogramma. Defect was filled in due to distal fragment lengthening with overlap of bone fragment ends. Foot queenus was liquidated. There was an open tibia fragments adaptation. The treatment result. One year's follow-up. Polylocal osteosynthesis. Patient with the following diagnosis: 15 centimeters post-traumatic diastasis defect of the right tibial bone. The defect was filled consecutively at 2 levels by lengthening of proximal and opposite distal fragments of tibial bone. 1 year's follow-up. Patient with post-traumatic tibia defect. The defect was filled in due to tibial fragments lengthening to each other, 2 destruction regenerators, the open fragments adaptation. The treatment result. The patient with post-traumatic tibia defect, the was result of proximal fragment lengthening, ischemic regenerate. The defect was filled in due to tibia fragments lengthening toward each other. Ischemic regenerate was compressed. 3 destruction regenerators. The open fragments adaptation. The treatment result. Patient with post-traumatic ulnar defect. Failed joint of radial bone, the scheme of osteosynthesis. The ulnar defect was filled due to consistent multi-level lengthening. The open ends fragments adaptation. The treatment result. Patient with post-traumatic tibia defect, the tibia defect was filled due to consistent multi-level lengthening. The fragments are coherent. The close ends fragments adaptation. The treatment result. Technologies of tibia fibula synostosis. A patient 3 years old, diagnosis with secretary of hematogenesic osteomyelitis, subtotal defect of tibial diaphysis, reconstruction of tibia-bound transporting fibula, short-term follow-up after 6 months. We use non-consecutive technologies, decisions for filling in bone defect and correction of pseudoarthrosis using transosseous osteosynthesis. Post-traumatic patellar failed joint, the open adaptation, transosseous osteosynthesis. The treatment result. The scheme of transosseous osteosynthesis at clavicular failing joint, patient with clavicular failing joint. The open adaptation of the fragments ends, transosseous osteosynthesis is made by the scheme. The treatment result. The other patients with clavicular failing joint, the open adaptation of the fragment ends, transosseous osteosynthesis, the treatment result. Patients with clavicular defect. Free bone plastics by fibula. Transosseous osteosynthesis is made in the scheme. Fixation 4 months. The treatment result. Patients with sarcoma Ewinga. Treatment result. Osteogenetic sarcoma of the tibia. Post-resection defect was filled by 1 level lengthening of the distal fragment. Adamantinoma of the right tibia, the scheme of the osteosynthesis. Segmental defect of the tibial diaphysis was filled by lengthening of fragments towards each other. Osteoblastoclastoma, the scheme of the osteosynthesis. Post-resection defect was filled in by 3 level lengthening of the proximal tibial fragment. The treatment result. Osteoblastoclastoma of proximal metaphysis of the right tibia. the schema of osteosynthesis, free bone plastics, transosseous osteosynthesis, the treatment result. Patient with humeral bone cyst, pathological fracture, transosseous osteosynthesis of the humeral bone, the cyst compression, the wires are covered with hydroxyapatite, the treatment result. Patient 56 years old, diagnosis with post-traumatic stiff failed joint of femur. Deformity was corrected during 30 days. Intramedullary nail osteosynthesis. Patient with round fused femur fracture, shortening is 7 centimeters. The femur osteotomy, lengthening is 2 millimeters a day. Intermediary nail osteosynthesis. Patient 24 years old, diagnosis post-traumatic pseudarthrosis of femur, shortening is 4 centimeters. Intermediary locking nail. Rare osteosynthesis of the femoral nail, the closed remaining of pseudarthrosis, the compression of pseudarthrosis with the Ilizarov frame, the lengthening of the femur. Distraction 41 days, fixation 60 days. Short-term follow-up, the Ilizarov apparatus is removal. Distal locking rod. Ilizarov method is highly effective in treatment of patients with a long bone defect. Conclusion. Thank you. Thank you for your attention.
Thank you very much. There are 1 or 2 questions, quick questions. Anybody wants to ask?
You did 3-level corticotomies. What about the soft tissue complications? 3-level corticotomy for bone transport in tibia.
We didn't have any problems with skin.
Возможные проблемы только в васкуляризации фрагментов.
The main problem is with the blood supply of fragments.
Когда вы выполняете остеотомии, 3 остеотомии, вы должны понимать, что отломки должны быть адекватно кровоснабжаемы.
So when you are making 3-level osteotomy, you must be sure that all fragments have good blood supply.
Rate of distraction of each fragment, each level. Distraction level.
Yeah.
How much you distract?
Сколько на каждом уровне дистракции?
Все зависит от уровня удлинения.
So it depends on the level of hole enlargement.
Для нас достаточно типичная ситуация, когда пациент поступает с сформированным ишемическим регенератом, допустим, на голени.
So for us, it's quite usual to see their bed regenerates, hypovascular regenerates.
В этой ситуации мы выполняем остеотомию не только для замещения дефекта. Вот в этой ситуации ишемический регенерат.
You see it's ischemic regenerate, bed ischemic regenerate.
Уже включили.
Can you show us presentation again? Please switch on projector. Yeah. It's okay. So it's ischemic regenerate.
Это достаточно типичная ситуация.
It's typical.
В этой ситуации мы выполняем остеотомию выше ишемического регенерата.
We usually make another additional osteotomy upper the ischemic regenerate.
Имеем достаточно небольшой фрагмент.
And have very little fragment after this.
Но это метафиз.
But it's metaphysis.
Здесь проблем не бывает.
And we have no problem in metaphysis.
Для замещения дефекта еще используем 3-й уровень остеотомии.
So for closing the gap, we're using 3rd osteotomy.
Задача вот этого уровня удлинения.
So the aim of this locus of elongation
Создать компрессию ишемического регенерата.
Is to make the compression of ischemic regenerate.
И заместить дефект.
and to get away the gap. So to get the bone into the gap.
Мы получаем решение 3 задач.
So we solve 3 problems in one solution, in one frame.
В рамках одной технологии.
In one technology.
3 регенератора.
So 3 regenerates. First one is chemic. Я повторю просто по почкам. So first one is chemic, and the idea is to compress it. To press is chemic regenerate, bed regenerate. So we make additional osteotomy. And another osteotomy, one more, why it is so many, third, is to make elongation.
You have used this intramedullary nail with fixator.
Yeah. Сколько пациентов были инфекции?
Пациентов у нас немного на сегодняшний день.
So not so much patients till now.
Около сотни.
About 100 with nailing.
Проблем с комбинированным использованием на сегодняшний день не было.
But we until now, fortunately, we haven't any problems with the nailing and Ilizarov technique because this combination.
К сожалению, у нас есть проблемы с чисто интермедулярным остеосинтезом.
But we have some problems with only intramedular osteosynthesis.
Но оценивая результаты, почему это произошло, мы знаем причины.
But we know the cause of these problems.
Просто-напросто где-то мы не соблюли технологию.
Maybe sometimes we were making some mistakes in the using of intramedular nailing, because we are experts in Ilizarov techniques, but we are not experts in nailing yet. Maybe we made some mistakes.
При комбинированном использовании, вероятно всего, имеется повышенное внимание к этой технологии.
So now we have just new approaches to this, and we take a great attention to this task.
Мы более тщательно отбираем больных.
So now we have a very good selection of patients for this technique.
И взвешиваем все риски.
And try to understand all risks, and then to make a right decision. So now we have a special program for combinations.
Поэтому пока нет.
So now it's not, for us 100 patients is not a lot.
Okay, thank you very much. May I invite Dr. G.S. Kulkarni to talk on